A warm welcome and to another inspiring session of Heartline mini series of physiology, where the rhythm of the heart meets the breath of the sciences. Today, we will discuss about one of the most intricate and fascinating aspects of cardiopulmonary physiology, that is the pulmonary vascular resistance. The concept, which begins in the base of the basic science, ultimately shapes into our every decision making inside the operating theater. From the ventilator settings to the vasoactive choices, from the perfusion strategy to vein of bypass. So, the understanding the determinants of pulmonary vascular resistance is not only just about the numbers or equations, it is about the appreciating the delicate balance between ventilation, perfusion, and the vascular tone that sustains every heartbeat and every breath during cardiac surgery. So, we are deeply honored to have with us our respected teachers, Dr. Arnab Samanta. Though he is very junior, but he is one of the best teacher I have known, whose clarity of thought and depth of understanding continues to inspire our next generation of the anesthesiologists. His ability to translate the complex physiological principles into practical insights practice. You can start on.
Okay, ma'am. Thank you, ma'am. Thank you for the wonderful introduction. So I'll start with pulmonary vascular resistance, the basic physiology surrounding it. So, what is pulmonary vascular resistance? So, PVR represents the resistance offered by the pulmonary circulation to blood flow. So, it actually has a bearing on the right ventricle. So, it quantifies how much pressure the right ventricle must generate to drive the blood through the lungs. So, the formula of PVR is MPAP, that is mean pulmonary artery pressure, minus the left atrial pressure divided by the cardiac output. Normal values are 1 to 2 Wood unit or 80 to 160. This varies to from book to book. So mostly it is 80 to 160 dyne second centimeter to the power minus 5. Now coming to the natural history of PVR. Ma'am, am I audible, ma'am?
Yes, you are audible and very
Okay,
much visible too. Yeah, please
thank you.
continue.
Okay. So at term or near term, the SVR and the PVR are matched. Mostly they are equal. At birth, what happens when the baby breathes in, the lung expands and the arterial oxygen increases, and there is a rapid fall in the PVR due to vasodilation. Then again, at a different stage of life, at 6 to 8 weeks, there is a slower fall in the PVR due to thinning of the vasculature. This is due to modification of the vasculature with subsequent changes. Then further the PVR goes down, and approximately at around 2 years there is a further decline which occurs due to recruitment of further alveolar units and their associated vessels. So this is the natural history how PVR develops into the adult level. Now, what is the basic difference between the pulmonary and the systemic circulation? So the pulmonary circulation is a low pressure, low resistance and a high flow system, and it is highly recruitable and compliant. Whereas the systemic circulation is a high pressure, high resistance and low compliant system. The pulmonary vessels are thin walled and distensible. What does this mean? This means that when if we are able to increase the pulmonary blood flow, by increasing the cardiac output, the distensibility actually contributes to reduction in the PVR. Another important thing is the response to hypoxia. It is opposite to the systemic circulation. That is, when there is hypoxia, there is vasoconstriction. This is a very important factor. So now, how is the distribution of pulmonary vascular resistance is there in the lungs? So PVR actually is contributed by the arteries, capillaries and veins all, but maximum contribution is from the veins and the capillaries. But when there is prolonged increase in high blood flow through the lungs, there are certain changes in the overall vasculature, which I will discuss later on. So that may lead to a irreversible change and will lead to pulmonary hypertensive disease or pulmonary vascular occlusive disease. So what are the factors that affect PVR? First, the pulmonary blood flow, lung volumes, HPV, I'll discuss this, metabolic and endocrine factors, autonomic nervous system and blood viscosity and effects of drugs. So how does pulmonary blood flow play a role? So if there is increase in pulmonary blood flow, there is a decrease in pulmonary vascular resistance and vice versa. So how does this occur? It occurs by the distension of the pulmonary capillaries that I initially said, and also by the recruitment of previously collapsed and narrowed capillaries. So this is for the pulmonary blood flow. Now coming to lung volume. Lung volume, there is the relationship between the lung volume and the PVR is a U-shaped graph, and the pulmonary vascular resistance is lowest at the FRC. So it is very difficult to practically achieve this, but theoretically it has been seen in experimental studies that the pulmonary vascular resistance is lowest at the FRC. When there is overinflation, the PVR rises, and if there is underinflation, the PVR also rises. So it is optimum at the FRC. Now coming to HPV. This is another very important factor that contributes and helps us actually during one lung ventilation and also in pathophysiologic processes. I'll discuss it in my next presentation. Now coming to the metabolic and endocrine factors. So several vasoactive agents which are secreted normally in the body like catecholamines, arachidonic acid metabolites and histamine, all these actually increases PVR. So as we all know, histamine causes systemic vasodilatation, but in the lung it actually increases the PVR. Hypercapnia and acidemia also increases PVR. These are also metabolic factors, and hypothermia, as we all know, hypothermia increases PVR and suppresses it also. Hypothermia will suppress hypoxic pulmonary vasoconstriction. So it is very much important practically to maintain the temperature of the patient during a one lung ventilation, because if there is hypothermia unnoticed, then the PVR may rise and there may be a difficulty in maintaining the saturation and ventilation parameters of the patient. Now coming to autonomic nervous system. The alpha 1 receptors are present in the pulmonary vascular bed and it causes vasoconstriction. The beta 2 causes vasodilatation, and muscarinic M3 receptors, they cause vasodilatation. Blood viscosity is another parameter. Blood viscosity. This blood viscosity parameter is important in patients who are actually cyanotic because they have increased RBC, and in patients where there is increased pulmonary blood flow due to a congenital disease, there actually this has a very important bearing, and the PVR increases rapidly and leads to early pulmonary vaso-occlusive disease. This is very important. So then comes the effect of drugs. Pulmonary vasoconstrictors are mostly adrenaline, noradrenaline, adenosine. As we all know, adenosine, when we are giving, we should be careful if you are using adenosine. Other pulmonary vasodilators are nitric oxide, uh, milrinone, sildenafil, and other endothelin receptor antagonists and soluble guanylyl cyclase analogs, all these drugs. So coming to pulmonary blood flow, just this is one graph, as I already said, the pulmonary artery pressure, and here on the x-axis, and in the y-axis there is PVR and pulmonary blood flow. As we can see that the relationship is vice versa. As the PVR decreases, the pulmonary blood flow increases, and vice versa. So what happens if there is chronically increased pulmonary blood flow, especially in patients with VSD, I'm telling, or maybe other congenital disease which has increased pulmonary blood flow. So there are certain changes in the pulmonary vascular bed. So these changes have been described by the Heath-Edward classification. This is a very important classification, and grade up to grade 3 the changes are reversible, and after grade 4 these are irreversible. So this is very important. So the characteristic of pulmonary vaso-occlusive disease is the plexiform lesions, which suggest this actually has to be done by histopathology, which is not always practically done, but it is for academic discussion. So plexiform lesions seen in H means histopathology will give us an idea that whether the changes are irreversible or not. But practically we do the vasoreactivity test. I will discuss it later on. Now coming to the lung volume and PVR relation. I already have said this. So the graph, as we can see, it is U-shaped. This is the graph. It is U-shaped. This is at the residual volume and this is at the peak of the lung capacity. And this is the FRC. And here we see the pulmonary vascular resistance is lowest at the FRC. So what happens at low lung volumes? That means when we are ventilating at very low lung volumes, the extra alveolar vessels collapse and the PVR rises. And at high lung volumes, the alveolar capillaries are compressed and the PVR increases. So it is preferable to ventilate at the FRC. Though it is very difficult to practically achieve, how to understand this is very difficult. So now coming to the passive determinants of PVR. So lung volume, as I already said, then pulmonary arterial pressure. As the pulmonary arterial pressure increases, due to mostly because of increased cardiac output, what happens, there is increased recruitment and distension, which leads to reduction in PVR. But this is not, but this does not happen if the pressures are chronically raised. If the pressures are chronically raised, then there will be changes in the pulmonary vascular bed. So it will again lead to pulmonary hypertension, which is again irreversible. Blood viscosity, as I already discussed, increased hematocrit increases PVR. Now coming to the active, this also mostly I have discussed. So alveolar oxygen, I will discuss HPV in more detail. So if there is a decrease in the alveolar oxygen, the PVR increases. So if it is generalized, this increase in PVR, if it is generalized, then it is very difficult to manage because the RV cannot withstand high afterload. So, but if it is regional, it is actually favorable. It is actually favorable. So then again, we all know this. If there is acidosis and if there is increased carbon dioxide, there is vasoconstriction and PVR increases. Temperature similarly, increase in temperature causes vasodilatation and PVR will decrease. Catecholamines, nitric oxide, endothelin influence the vascular tone. As I already said, the NO will decrease, endothelin will increase, catecholamines will mostly increase. Now the effect of gravity. So this is another important thing. So what happens, the west zone, I'm not going into the details. Mostly, as we know, that the contribution of the to the PVR is mostly by the veins. So here, as we can see in the zone 3, the vein has a good amount of blood supply. So these venules actually contribute to the increase in PVR. So blood flow and vessel diameter is greatest at the lung bases, that is zone 3 mostly, and so it will lead it will have lower PVR. Now coming to the measurement of PVR. So direct measurement of PVR is done by the Swan-Ganz catheter, as we all know. But here one important thing is that the formula for the PVR is actually left atrial pressure. But it is very difficult to measure the left atrial pressure through the right heart system. So we take the PCWP for that purpose. So mean arterial pressure minus PCWP divided by cardiac output into 80. It will give us the PVR in dyne second centimeter to the power minus 5. Now echocardiographic parameters. So mostly it is done from the tricuspid regurgitant jet Vmax. So here are some other formulas which can be utilized. These are actually formed from regression actually. This formula we all know. This one. So these formulas may be applied, but it is practically very difficult to do that. Now coming to the clinical importance of PVR. So as we all know, very simple, if PVR increases, RV afterload will be higher, and RV, as we all know, is very sensitive to high afterload. So RV failure, and if chronically raised, there will be RV hypertrophy, and eventually it will go to failure, and there will be increased chances of arrhythmias also. Then chronic hypoxia, pulmonary embolism, and ARDS. This will lead to pulmonary hypertension, which will again have a bearing on the RV, and it may lead to acute RV failure, and in case of chronic hypoxia, it may lead to cor pulmonary, that is RV failure due to a lung cause. So in patients, perioperative care patients, we always would love to have a less PVR, especially in patients with right heart failure. And so most importantly, we have to maintain normoxia, normal temperature, and we have to avoid acidosis. And another important thing is that we have to maintain adequate depth of anesthesia. So pain will also increase the PVR. So this is one important thing. Now coming to the vasoreactivity testing. So this is one. This is mostly done for patients who have irreversible, where we need to check whether the patient has gone into irreversible pulmonary arterial hypertension or not. So there we go for the vasoreactivity test. So there are several agents which are used. So nitric oxide, inhaled nitric oxide, I am not going into the very details. Epoprostenol IV, adenosine is currently not used anymore, and iloprost may be used, inhaled iloprost. So these are the things, and the recommended duration and incremental doses are given here. So what is the criteria for reversibility? If there is a reduction in the mean arterial pressure of more than 10 millimeter of mercury to an absolute value of mean arterial pressure of less than equal to 40 millimeter of mercury without a change in cardiac output. This is important. If blood pressure falls, automatically the pulmonary artery pressure goes down. So that will not satisfy the criteria. So we need to see that the cardiac output remains unchanged. So if we are getting this, then we start the therapy with a calcium channel antagonist. If there is no change, then we go for either a combination therapy, or combination therapy including IV, or a combination therapy of oral, or a triple therapy may be initiated. Triple therapy mostly has macitentan, which is a endothelin receptor antagonist, Selexipag, which is a PGI2 analog, and this thing, Selexipag, and I'm forgetting another one. Sorry, Riociguat. Sorry, Riociguat, which is a soluble guanylyl cyclase modulator. All of these are started. And if there is no improvement, then we can go for a atrial septostomy just for a stopgap, and eventually we need to go for a lung transplantation. So these are the practical aspects that are here. So now summarizing mostly the determinants, if we ventilate the lung at beyond the FRC or below the FRC, the PVR increases. Hypoxia, acidosis, hypercapnia increases PVR. And endothelin, thromboxane, these are endogenous products which increases the PVR. Generalized HPV will increase PVR and will have a unfavorable effect on the circulation. And other, if pulmonary pressure rises or cardiac output increases, there is reduction in PVR due to recruitment and increased distensibility. Nitric oxide and prostacyclins reduces the PVR. So this is mostly about the pulmonary vascular resistance. I'll go into the HPV part. So coming to HPV. So any questions, ma'am, or I will proceed?
Any question from anyone? Anything to re-explain? Or no, can you re-explain that part,
Ma'am,
the
please.
FRC and the relationship between uh, the tidal volumes that
Yes.
we should keep for all the patients?
Yes.
Yes, this thing.
Yes. So as we can see, this is a U-shaped curve where in the x-axis we are plotting the lung volumes, and in the y-axis is the pulmonary vascular resistances. So the shape of the, this is experimentally derived, the it is U-shaped. Why it is U-shaped? Because at the two extremes of the ventilation, the PVR will be higher, so which is unfavorable. So at low lung volumes, that means when we are ventilating at very low lung volumes, which are actually not suitable for the size of the patient, then what happens? The
Okay,
extra
what do
alveolar,
you mean by extraalveolar vessels?
extra alveolar vessels are the vessels that are, means the some of the vessels, when they some surround the alveoli, ma'am. So they are the alveolar capillaries, mostly, which are compressed during the high lung volume ventilation. During the low lung volume ventilation, so what I am saying is, if this is the alveoli, so blood vessel will come and it will form a capillary network like this.
Mhm.
This is compressed at high volumes. So when there is excess inflation of the alveolus, this will compress on this vessel and it will contribute to increased PVR. And these vessels, if the lung is not getting ventilated, so the part will be collapsed. So when that collapse occurs, it actually compresses on this extra alveolar vessels, ma'am. So it
Mhm.
increases the PVR.
Okay, great. Great. Thank you.
Yes. Ma'am, anything? Now should I proceed, ma'am?
Please proceed to the next part.
Yes, sure. So, coming to hypoxic pulmonary vasoconstriction, friend or foe. So, this is our topic. So, I'll start with what is HPV. So, HPV is the intrinsic ability of the pulmonary arterioles to constrict in response to low alveolar oxygen tension. So, what it does, it diverts blood flow away from the poorly ventilated alveoli towards the well ventilated regions. and it optimizes. Eventually what it does is, the effect is, it optimizes ventilation perfusion mismatch, or matches the ventilation and perfusion, and also improves systemic oxygenation. So now coming to, it was first actually described by von Euler and Liljestrand in 1946. What they did, that they demonstrated that using a hypoxic mixture of 10.5% oxygen and nitrogen led to increase in pulmonary artery pressures. On the contrary, 100% oxygen, when it was used, it was associated with a reduction in pulmonary artery pressures. So this remarkable finding led to the development of the concept of HPV. So mostly HPV occurs in the small precapillary pulmonary arterioles. So it is triggered by alveolar. This is very important. It is triggered by alveolar partial pressure of oxygen, not arterial. So hypoxia, when hypoxia occurs, that is, there is less oxygen inside the alveolus. It is usually triggered at a alveolar oxygen tension of less than 60 millimeter of mercury and peaks at 30 millimeter of mercury. So it begins within seconds and peaks in 5 to 10 minutes and can sustain for hours. And it is divided into two phases. One is the early transient phase and another is the late sustained phase. I'll discuss this later. So what happens? This is the mechanism basically. So the alveolar partial pressure of oxygen is sensed by the pulmonary arterial smooth muscle cells. That is this pulmonary smooth muscle cells. So this cell senses hypoxia. What it does is that it inhibits the potassium channels first. So on inhibition of the potassium channels, there is increased secretion from the stored of calcium. So it leads to a transient rise in calcium, which leads to the transient phase 1 constriction. So once this happens, the calcium enters via the voltage, starts to enter via the voltage gated calcium channels also, and there is a sustained rise in the calcium. This is eventually it happens, and there is a sustained phase 2 constriction. So these are the two phases. Another important factor is the endothelium has also a contribution to this HPV. Endothelium secretes several factors like the endothelin. Endothelin, as we all know, is a potent vasoconstrictor, and therefore it causes local vasoconstriction by increasing the calcium sensitivity, and it also reduces the nitric oxide production locally. So whatever vasodilatory effects the nitric oxide was having is negated by the secreted endothelin. So this is mostly the pathophysiology of how it occurs. Now the physiologic role of hypoxic pulmonary vasoconstriction. So HPV as a friend. So how it helps us? So it is most important in patients where we are doing a thoracic surgery and the patient is in the lateral position and a single lung is being ventilated. So without our friend, that is HPV, we could not have performed this task. It would have been very difficult to maintain a good oxygenation for the patient. So why I say this is that, how does HPV help during one lung ventilation is that in the dependent lung, normally 60% blood flow will be there. Dependent lung. Non-dependent lung, 40% blood flow will be there. And mostly 5% physiological shunt exists in each of the lungs. So 55% effective in the dependent lung and 35% effective in the non-dependent lung. Now, what happens? When one lung ventilation is initiated, this non-dependent lung is devoid of oxygen. So, alveolar oxygen tension is reduced and then HPV comes into play. So what it does, if there was no HPV, then almost only 55% of the blood flow that is reaching the dependent lung would have participated in ventilation perfusion. Because of HPV, this percentage will starkly reduce. I'm saying how. So what happens? Because of HPV, approximately 50% of blood is redirected from the non-dependent, non-ventilated lung to the ventilated and dependent lung. So 50% of 35, which was the effective blood flow to the non-dependent lungs, is diverted to the dependent lungs, which is being ventilated. So 50% of 35 is 17.5%. So approximately 55 plus 17.5%, that is 72.5% participates in ventilation and perfusion. This is only possible because of HPV. If there was no HPV, only 55% would have participated in ventilation perfusion. So this is how HPV is our friend. So when is HPV our enemy or foe? When there is global or chronic hypoxia. So considering a patient with COPD, a chronic hypoxic disease where lung parenchyma is involved and there is overall the oxygenation is reduced and there is widespread vasoconstriction. So what happens? If there is widespread vasoconstriction, the PVR will overall rise, the pulmonary artery pressure will rise, there will be increased RV afterload, and eventually RV hypertrophy and failure, that is core pulmonary, as I already discussed. So chronic HPV leads to pulmonary vascular remodeling and hypertension. So examples are COPD, ARDS, high altitude. This is a physiological change actually, because at higher altitude the partial pressure of oxygen is low. So the body's natural tendency is to reduce, not the natural tendency means it is a protective mechanism to reduce the pulmonary vasculature. So that is why they have a better reserve, but they have also higher incidences of raised PVR. So normally the patients or subjects who are coming from higher altitudes will have a higher PVR. This is a normal phenomenon. So this I already discussed mostly. HPV and anesthesia. During one lung ventilation, HPV reduces the shunt fraction and maintains oxygenation. So excessive volatile agents more than 1 Mach and high FiO2 alkalosis can inhibit HPV. So preservation strategies, we can go for a total intravenous anesthesia for maintenance, and FiO2 should be kept to minimum range where we can achieve adequate oxygenation and avoidance of acidosis, hypothermia, as I discussed previously. HPV is critical in maintaining gaseous exchange during thoracic surgery and anesthesia, as I already said. So now, what are the modifiers? This we all know. Mostly, I'll just be going through. High FiO2 abolishes the HPV by restoring oxygenation, and acidosis enhances HPV, alkalosis suppresses it, hypothermia enhances, hyperthermia suppresses HPV. Volatile anesthetics mostly inhibit HPV in a dose dependent manner. If it is mostly more than 1 Mach, the HPV is decreased. IV anesthetics usually have a minimal role, but propofol has some literature evidence suggesting that it has a role in reducing HPV. Vasodilators like NTG, SNP, this will all reduce HPV. Vasopressors, phenylephrine may preserve it. This is again doubtful. So key mediators, these are the vasoconstrictor which are endogenously secreted, or the pathways which facilitate vasoconstriction and enhance HPV are endothelin 1, thromboxane A2, reactive oxygen species. This mostly affects the mitochondrial, and there is some role of the mitochondria which is very complex. I'm not going into the details. Even I do not know also much detailed about the mitochondrial influence on HPV. And another is the rho kinase. Vasodilators again inhibit HPV, which are inhaled nitric oxide, prostacyclin, adenosine, cGMP, and cyclic AMP pathways. These are all the drugs that are mostly used for pulmonary arterial hypertension. Summary and take home points is that HPV is a unique intrinsic local reflex, not neurohumoral. It acts as a friend when localized, foe when it is diffuse, it is harmful. So it is crucial in anesthesia. Without HPV, actually, it would have been very difficult to maintain one lung ventilation anesthesia. So actually, in patients with, if you are ventilating a one lung ventilation patient with 100% oxygen, it is, we are able to achieve a pulmonary arterial oxygen tension of more than 150 millimeter of mercury almost, if the lung is otherwise normal, obviously lung normal. So so this is mostly my presentation. Thank you, ma'am. Thank you everyone for your patient listening.
Thank you very much, Arnab. Any questions from anyone?
Oh
Kolkata?
no, nice presentation. Oh no.
Thank you, sir.
Now, you have told all the physiology and the pharmacology behind HPV so nicely. Now, what are the clinical aspects you think most commonly we deal? If you like in a patient who is a baby posted for TOF, so
Yes.
like how you like to have the clinical effect? A patient taking baby posted for a TOF, say maybe less than 2 years old baby. So how you like to take him to the OT to prevent this HPV?
Sir, actually, in patients with TOF, actually there is the alveolar oxygenation is not an issue per se, but the means the pulmonary circulation is deficient. Means there is
Okay.
reduced pulmonary blood flow. So what will happen is that actually in the post CPB period, actually, if we are unable to manage the rise in PVR, or if there is generalized HPV, it will have a bearing on the already failing RV, which is already hypertrophied and mostly abnormal with fibrotic changes also in case of TOF. So it will have a increased risk of winning from CPB will be an issue, and even in the post-operative period also there may be some issues. So we need to maintain post-operative ventilation. We have to maintain ventilation, and we have to, as we are using mostly smaller size tube. So there is another issue. So we have to avoid, means we have to do suctioning routinely, which is done mostly. So so that the tube resistance does not increase and the ventilation parameters are maintained. So hypoxia, hypercarbia, all, as we all know, has to be prevented at all costs. And as we all know that it is also hyperviscosity state. TOF means the hematocrit is very high. In the post CBP period also, because of the physiology of the TOF patients, we need to keep the hematocrit higher. So a lower hematocrit is actually not favorable for these patients. So we have to balance the rest of the parameters so that we can maintain a good amount of hematocrit for the TOF patients in the post CPB period and the intensive care unit. And lung ventilation is another very important parameter. As I said, theoretically, that we have to maintain ventilation at the FRC, means our tidal should not be very high, or the pressures should not be very high or very low tidal. So it will have a bearing on the RV, because the PVR will be raised. So mostly these are the considerations that I can think of at this time, sir.
Yeah, great. Now, can you tell, can anyone tell, it may not be you, like now, what are the aspects? Do you think a normal lung is better, or a COPD, or a heavy smoker who is being posted for a thoracic or any one lung ventilation requiring surgery to prevent this HPV or having a market effects of HPV on table?
So, sir, one thing is
Which
that
which patients? My question in like
uh,
is which patients you think that HPV will set in more markedly? A normal patient with a normal lung physiology, or a patient who has got already a COPD with fixed chronic COPD, who's got a fixed pulmonary function, FEV1 less than 70% or so, and or maybe having a chronic interstitial lung disease.
yes. So actually, in patients with COPD, it will, if the patient is means severe COPD, it will be difficult to for HPV to set in, because there is chronic hypoxia was present in that patient. So HPV in those patients will not be, means there the vasoconstriction is already at the fullest, so that will actually eventually have a bearing on the RV also. So these patients who are at end stage COPD, it will be very difficult to manage one lung ventilation for a prolonged period. But
May
on the
not be, we
yes
may
sir.
not be talking about end stage. This
Yes
is
sir.
on daily basis when you are having patients,
Ah,
a patient who is having a normal PFT and anyone having an abnormal PFT. Whom do you think that the HPV, like hypoxia, would rather stimulate HPV more? A normal lung or a COPD patient or a fixed pulmonary function test, an abnormal PFT?
Arnav, you should tell like Dr. Devendu's want to ask, na? It's like a normal lung. Those
yes
patients having normal lung is more prone for this HP rather than those patients having some sort of
easy.
PFT abnormality. That's
Yes
what you are trying to say actually.
yes sir. Yes
So
sir.
that is not regarding end stage COPD or whatever.
Okay sir.
So Dr. Devendu is asking one patient is COPD, another patient is
Not
non-COPD
COPD.
for
Yes
one
sir.
lung ventilation.
Yes.
So whom you think is more prone for this HPV?
The
Which
patient
patient?
with COPD will be having more ESR, but I don't know the exact reason why this will be happening, but they will be more prone to this advantage.
Why?
Will get advantage.
If the reasoning is not there, then why do you think? Like you were saying, ki these patients, they are not too much affected with this HPV as the CO2 is to the highest and the HPV is already at the fullest.
Yes,
So
sir.
why the
Actually,
normal lung, do you think normal lung is going to behave like they are more prone for this HPV mark set in those patients in case of one lung ventilation? Do you agree or not? So I think Dr. Dubende will tell.
Yeah, in our experience, I think normal
yes,
lungs do have more episodes of hypoxia than a COPD, and they do
Yes.
have more chances of HPV setting in, which
yes, sir.
can be detrimental in managing a one lung ventilation on table rather than a patients who are having an abnormal PFT, not an end stage. End stage scenario is different. So if you have PA catheters and a saturation monitor also, the moment you set in a one lung ventilation in a patient with normal PFT, they do have more chances of hypoxia immediately than a COPD patient, because already these patients are having a low PO2. They get used to that low PO2 and a high normal PCO2 for a long time. So the body, they don't respond to this drop in the saturation.
Okay, sir.
Yes, you are right. Actually, Arnav was telling the same thing, just he quoted the end stage COPD.
This
Otherwise, he
this is
was
our
also,
this is our experience also.
yes.
Thank you, sir.
So basically, what I like to say is like it's more easier to manage one lung ventilation in a
See,
more a poor PFT rather than having a normal PFT. And coming to that, over years we have seen PFT actually really doesn't make much difference in having a set that whether intraoperative patient will be able to tolerate one lung ventilation or not. Obviously, it does set that postoperative outcomes, but
yes, sir.
not the intraoperative.
Okay. Thank you, sir.
Any other queries? So thank you everyone for joining this evening Heartline session. And really, what a truly enriching journey it has been, from the elegant equations of pulmonary vascular resistance to their very real implications in the operating theatre. Arnab has beautifully reminded us about the physiology is not just a theory, it is the silent guide behind every ventilator setting, every drug choice, and every decision we take. When the heart and lungs are our head. His lucid explanations have turned a complex concept into a living, breathing part of our clinical reasonings. So, on behalf of Heartline team and the IACTA West Bengal and all of us here, I extend our deepest gratitude to Arnab for sharing his time, wisdom, and inspiration to us, to all the participants. Thank you for being part of this academic pulse that keeps the Heartline alive. So let us carry forward today's learning into our practice, where the knowledge meets compassion and science meets the soul of feeling. So until we meet our next Saturday 7 p.m. sessions, stay connected and keep your heartline strong. Thank you very much and good evening.